All right, Philip, thank you so much. Good morning. Such energy, such excitement. And so today I have the privilege of giving the Don Wilson lecture on Endo-Hepatology, a journey of partnership. So I will be talking about journey, and be careful. You know you're getting old when people keep inviting you to talk about history of or journey of. But anyway, journey. I will be talking about partnership, which is what Don Wilson and everyone here is all about. And obviously, I will contextualize that around endo-hepatology. So let's see if we can get this done in 30 minutes. These are my disclosures. Now, journeys tell a story, and they inform the future. The journey to endo-hepatology, is a short journey, 65, 67 years from 1957 with the first flexible endoscope. So I also want to parallel that with the journey of the guy here in front of you who's 65 also. My journey actually, in many ways, started here in Hong Kong. This is Kowloon City Baptist Church on Argyle Street, 222 Argyle Street. I know that because my grandpa was one of the founding pastors in the 1940s. And so he immigrated to the States. And in 1959, I was born, and that's Grandpa on the left. And if you didn't recognize me, that's me. And so the reason why this is very poetic is as a medical student in 1983, I spent a good part of my year as a medical student. I took a year off, and I spent it in Evangel Hospital here in Kowloon, also on Argyle Street, under the mentorship of Professor Chapman and the team there. I learned the meaning of compassion, I learned the meaning of innovation, and I learned the meaning of how to think out of the box to help patients in need, even though you are resource restricted. This is now the hospital today, and every time I come to Hong Kong, I go and at least drive around and take some pictures. Dial forward. This is my family today, and we all wish you a great holiday. And this is our current Digestive Disease Center and our Digestive Health Institute. So I have a lot of gratefulness coming back to Hong Kong because of my roots. So we talked about journey. I want to talk about partnership because it's partnerships, it's relationships that drive progress, especially in endoscopy. So the relationships we have with industry, and for this lecture, I'll focus on Cook specifically, our relationships with one another across different countries and continents, and especially for endo-hepatology, we have a relationship with our hepatology colleagues. So no one knew more importantly about relationship than Don Wilson. And the origin story of Cook is that Norm Marcon approached Don Wilson as Cook Canada and said, we need wires, we need better instruments. And Don Wilson's question was, okay, what do you need? And it started with a suitcase full of ideas. And these are some of the stories that I was able to get from Minda, who is here, and I'm proud to have a chance to get to know her as well. So endo-hepatology, I was able to coin this term in 2012, so it's been over a decade, and it looks like the name is sticking around the world. And so I wanted to briefly highlight the journey, the relationships and partnerships in endo-hepatology. I'll touch on liver palpation, liver biopsy, shear wave elastography, portal pressure measurement, and EOS-guided vascular intervention. So from the beginning of time, for 20, 30 years, every time I see the liver, I'm so tempted to palpate it. So here's my everyday palpation of the liver, and I got a good sense of cirrhotic livers or normal livers. So I remember teaching this to Marvin Yu at Harvard at the Brigham, And to my heartfelt surprise, he sent me this manuscript a few days ago. And the study he did on 70 consecutive patients was EOS liver palpation as a screening tool for advanced fibrosis and cirrhosis. And what he showed in these 70 patients is if you measure the indentation just simply by turning the big knob up against the liver, it's better than FibroScan. And it's superior to transelastography for predicting cirrhosis. If you use less than 3.5 millimeter indentation, 100% prediction of ruling out advanced fibrosis. Greater than 4 millimeter indentation, 100% predictive value to rule out cirrhosis. So this is a very inexpensive tool. It's just a matter of a few seconds of palpation. And for me, it just highlights the beauty of partnerships and relationships as we teach our younger fellows and as we demonstrate cases around the world. You never know what will come out of it, which is wonderful. It speaks to the fact that we are indeed a global village. EOS liver biopsy has a longer journey, right? It was in 1992 that Peter Vilman published the first case report of EOS-guided FNA of a pancreatic mucinous lesion. Those were our contemporaries. So in 1994, we published our series of EOS FNA. And in 1997, the four horsemen, this would be Moritz Wiersma, Peter Vilman, Mark Giovannini, and myself, we published 457 patients in gastro, which put EOS-guided FNA on the map. What about the liver? In 1999 is when we first did FNA of focal liver lesions. And then in 2001, we talked about detecting scant amount of ascites in patients who may have portal hypertension or peritoneal disease. In 2012, with the advent of the core needles, this is the ProCore series, we published the first ProCore biopsy of a patient with autoimmune hepatitis. And although we were elated that we had 8 complete portal tracks and safely done, this was EOS liver biopsy at its very infancy. We had a hard time convincing our hepatologists that this was the way to go for liver biopsy. So it took a good 10 years of different needles and techniques, and today I'm proud to say that our liver biopsy is better than any other modality, and our hepatologists, at least in my institution, are completely convinced that this is the way of the future. And that is because of the specialized tip core needles that we now have available, the fork tip, the Francine tip, the Mangini tip. And let me just give you an example. This is 8 centimeters of continuous core liver despite significant fibrosis. Here's another non-disrupted, non-fragmented 8-centimeter piece of liver, and this patient has stage 4 out of 4 cirrhosis. Look at the exquisite histology. Look at the way that the edges are cut so precisely and so evenly. The quality of the liver biopsy now is really exquisite. So I do want to share this 1-minute video that summarizes 10 years of thinking about how to optimize liver biopsy. So the video shows the right lobe of the liver. We measure it. And then this is using the Francine needle. And the first actuation, it's no syringe. I do prime it, but no syringe because you want the needle to just go fast and sharp. Then I do 2 additional actuations, so 3 actuations total. So after the first actuation, where there's no syringe to block the pressure on the backside, now I put on the syringe, I turn on suction and actuate, turn off suction, and then pull back and prepare for the third actuation. Third actuation, when I'm ready, turn on suction, fast actuation, and then turn off suction. You don't need suction when you're moving your needle back because you'll just fill your needle with blood. Now, as a safety precaution, we always stop and use E-flow Doppler to make sure there's no flow in the needle track, and then we can safely extrude the specimen. But this ladies and gentlemen, is our routine, everyday specimen, sometimes 15, 20, 25 centimeters of liver. And again, this is stage 4 of 4 cirrhosis from the right lobe. And then usually we do bilobar, so this is the left lobe of the liver. And again, you can see the architecture is intact, the evenness of the specimen, despite significant fibrosis and cirrhosis. So I think as we continue to capitalize on the optimal technique, we're going to see a real change in the practice of liver biopsy coming to the interventional endoscopist. I am also happy to announce that Cook has come out with a 22-gauge Francine tip, which just launched last week. So I do want to show you this video that I prepared for you from the first case, I think, in the States. So this is the left lobe of the liver. I'm going to now show you the needle, and there may be a little bit of sound there too. So that's the actuation. You see it's a very, very fast, quick jab. You want to maximize capturing, leveraging the sharpness of the needle. Again, no syringe on that first actuation. For the subsequent actuation, I put the syringe on, suction on, fast actuation, suction off, come back. This is the same technique that we talked about. So you can see the needle visibility is great, the responsiveness is great, the tension strength of the needle is very robust. And so in this patient, on the right lobe, I used the traditional 19 Francine, and on the left lobe, I used the new 22 Francine. And you can see on gross, on the right here, there's about 6 centimeters, 7 centimeters of continuous core. I just got back the histology, and you can see the quality of the 19 versus 22 is fairly comparable, a very well-cut specimen. So that's just fresh out, and we're hoping to see other needles come out, including a 19-gauge version. Now, when you do a liver biopsy, sometimes you can see that there's still flow in the needle tract. What do you do if there's flow in the needle tract and you're afraid to take the needle out because then it will be a bleed? So this is the EOS-guided blood patch delivery, which we published in Video GIE. So here, after 3 actuations with the 19-gauge Francine, you can see there's a lot of flow in that needle tract. And I waited 3 minutes, 4 minutes, 5 minutes, and it did not stop. What do you do? Whatever you do, don't just take out the needle, because then the blood will come into the liver capsule and into the peritoneum. All I did was put the stylet back in, push back 25 to 50% of the needle contact back into the tract. That was clotted blood, and it created a patch. It's nature's gel foam. It works beautifully. And so now you can see there's a blood patch there, and I can safely continue to pull the needle back. The flow stops at the blood patch, and you can safely then remove the needle. So please remember this in case that ever happens to you. And because we only delivered 50% of the needle content, which was mostly blood at the very end, we still got great specimen even on that single pass. Moving on to shear wave elastography. This is actually a very exciting addition to endo-hepatology. What shear wave is it's a second push pulse wave that generates a forceful ultrasound wave that creates a ripple effect. And the speed of the ripple effect in the perpendicular direction informs the stiffness of the liver. So a very stiff liver will have a rapid propagation of the wave, and a soft liver will have a slow propagation, and that's how we can calculate the liver stiffness. So I just want to show you this 30-second video of how quick and how easy it is. Here in the left lobe, we put the box region of interest, and we take 10 samples, and we see that it's 11.4 kilopascals. Here in the right lobe, we do 9 passes here, and the mean is 15.9 kilopascals. And then what's really interesting is we can also measure the stiffness of the spleen, because inflammation can make the stiffness of the liver different, but nothing can make the spleen stiffer than portal hypertension. So if your spleen is stiff, you essentially have portal hypertension. And so this study looked at parallel comparison of patients undergoing EOS shear wave elastography compared to conventional FibroScan and showed that it was very similar. But in 19% of these patients, the FibroScan was unreliable because of body habitus, and so these patients all had successful shear wave elastography. We reported this at DDW last year, 44 patients who had shear wave of right lobe, left lobe, and spleen, and a liver biopsy all at the same time. So we were able to calculate the operating characteristics, and a cutoff of 12.5 kilopascals in either right or left lobe of the liver highly predicted a F3 or F4 fibrosis. Then if we combine the shear wave of the left lobe of the liver with the spleen shear wave with a cutoff of 26, that had the highest operating characteristics with a positive predictive value of 80%, negative predictive value of 93% for predicting greater than 3 fibrosis score. So now we have a less invasive way of predicting fibrosis score, and this can then tell you, okay, we should go on and do a liver biopsy, or no, we don't need to do a liver biopsy, or you should go on to do portal pressure measurement, or we don't need to do portal pressure measurement. Again, this creates a more efficient, protocolized approach to endo-hepatology. Of course, one of my favorite topics to talk about is EOS PPG, portal pressure gradient measurement, which actually the journey started with Cook. And the story, the origin story of EOS PPG is as follows. After seeing the liver for 30 years, after seeing all the vessels that we could see, I kept asking the question, why can't we measure the pressure directly from these veins? Why do we settle for indirect measurement with transjugular wedge hepatic vein pressure? So I went to Cook, and they said, what do you need? I said, well, I need a transducer, I need a needle, and I need a non-compressible tubing that will transmit the force from the needle to the pressure gauge. And I want to try the larger needles, but I want to work my way down to the smallest possible needle because the smaller needle is safer for the patients. And Cook went into their bag of stuff, and somewhere in their reproductive health business unit, they had a pressure gauge, and so they sent it to me and said, here, try this. And so what did they use this pressure gauge for? For embryo transfer for reproductive health, to make sure that there's not enough pressure to fragment the eggs. So that was the origin, and and this is the simple handheld pressure monitor that was available. And then we did numerous testing, benchtop, many animal studies to look at safety, feasibility, and we also compared it with transjugular. And you all know that the animal study back in 2016 showed almost perfect correlation with transjugular pressures compared to EOS PPG through a 25 gauge needle. A year later, we published the first human pilot study, which you're familiar with, and that was in 2017. So we probably have a case today, but I did want to show you just a brief 1-minute video on how this is done. It's a relatively easy procedure. I'm here identifying the middle hepatic vein, and so my 25 gauge needle then just targets that middle hepatic vein about 1 to 2 centimeters from its coming into the IVC. And once in position, I flush the needle and then measure the pressure. Flush the needle, measure the pressure, flush the needle, measure the pressure, and I got 10, 10, and 11 millimeters of mercury. Then I identify the left portal vein, do the same thing, pressures 14, 14, and 14, and that's it. It's a very quick, simple, straightforward procedure. and you calculate the gradient by subtracting the hepatic vein average and the left portal vein average, and here it was normal at 3.67. So after many years of work, it finally became commercially available, and I do want to acknowledge partnership. This is Kevin Shimura, who was at that time the EUS product manager. Many of you know Kevin. And in 2020, we were able to be proud to say this is now available in the US, in Europe, and soon around the world. We published a more recent 64-patient series with concurrent liver biopsy in 2/3, and again, found technical success very high, no SAEs. And when we looked at the predictive value of the gradient greater than or equal to 5 millimeters of mercury, the prediction of fibrosis stage greater than 3 on EUS liver biopsy was 26 times higher if your EUS PPG gradient was 5 or greater. Obviously, we had to partner, and we rounded up our friends around the globe to put together this now international prospective multi-center trial, and this includes Chinese University, includes New York and Harvard, and so this initial team came together, and we presented this May at DDW, and a manuscript is pending. So that's a quick journey through EUS PPG. But the other interesting thing is now endo-hepatology meets endobariatrics. What do I mean by that? We realized that in our obese patients with NAFLD or MASH now, this patient in 2019 was obese and unsuspected had elevated portal hypertension with a EUS PPG of 6, and you can see the extensive steatosis and steatohepatitis and necrosis from the fatty liver. So despite trying to lose weight, she could not lose the 20% of total body weight that she needed to lose. So we performed endoscopic sleeve gastroplasty, and then a year later, she was able to lose 60 pounds. We repeated the EUS, we repeated the liver biopsy, and repeated the PPG. Now the gradient was normal. Let me show you the liver biopsy. On the left was her baseline liver biopsy. You can see all of the steatosis and the steatohepatitis. On the right is after losing 60 pounds with endobariatrics. There's no steatosis. There's no steatohepatitis. And the PPG was normal. We changed the gradient. What about the cirrhosis? What about the fibrosis? This was the fibrosis and cirrhosis that we had at baseline. And it improved. It didn't normalize, of course, but it improved dramatically. So again, partnership. So Sai Giappino at Harvard, she ran with this, and she performed EUS PPG before and after an endobariatric procedure called POSE, and she looked at this in 15 consecutive patients. The PPG decreased from 5.4, which is elevated, to 1.8 with successful weight loss. So almost 80% experienced a reduction in PPG, and I think this will be the wave of the future when we combine endo-hepatology with endobariatrics, especially when we're dealing with such a problem area of obesity around the world. And finally, we can't forget EUS-guided vascular intervention. And again, this is a partnership. So Marvin Yu has really spearheaded this segment of endo-hepatology, looking at EUS-guided intervention for gastric varices, and a combination of creating a scaffolding with coil, with glue, and now we're using gel foam, and gel foam seems to be working very, very well. And this is going to be an ongoing progress, filling out the treatment side of endo-hepatology. And of course, we know that these coils are also made in partnership with Cook. So in my final slide, I just wanted to show and underscore that the endohepatology and endoscopy in general has been, for me, an amazing journey of partnership. Those of you here in this room and our brothers and sisters around the world have really created an inexplicable, amazing global village around problems that we can solve together in endoscopy. And with that, I thank you for your attention.